Welcome. I want to talk today about the regulatory agenda to reduce the inappropriate use of antipsychotics in long-term care. I'm Dr. David Smith. I'm a practicing geriatrician in Brownwood, Texas. Our learning objectives for today, at the conclusion of the session, I hope that the learner will be able to report confidence in defining inappropriate antipsychotic use and the documentation that's needed in order to justify when the use is appropriate. I would hope that the learner will be able to express an awareness of the tactics to reduce inappropriate antipsychotic use in long-term care, and also to be able to list several strategies to encourage compliance with regulatory expectations by our prescribers. Finally, and this is a hard one to understand, I'll repeat it at the end of the talk because I think you'll get it better then, but I hope that the learner at the end of this session will be able to explain the barriers to compliance to the public and to legislators that is created by inadequate resourcing of long-term care and by a lack of evidence basis for non-pharmacologic treatments chosen without individualized care planning and delivery. I've been working on this problem since '87, and I'm desperate to move the needle. We haven't moved this needle. I have no conflicts of interest related to this presentation. This presentation is actually taken from an editorial that I did along with Dr. Keith Guest in the Journal of the American Medical Directors Association, the Journal of Post-Acute and Long-Term Care Medicine. That editorial was entitled, "Is Education All That Is Needed to Reduce Inappropriate Drugs in Long-Term Care?" I gave here an abbreviated history of antipsychotic reduction in long-term care. In 1987, the monumental turn in quality in long-term care was heralded by the new regulations that were shortcut named OBRA 87. Immediately following OBRA 87 and the psychotropic guidelines that were involved in that, we saw a 30 to 50% reduction in antipsychotic use around the nation. We did a hands-off approach to the antidepressants because it was clear to us that while there was some inappropriate excessive use of antidepressants, mostly the problem in those days was inadequate recognition and treatment of depression in long-term care. Let me point out that I was fortunate enough as a new doctor into long-term care to be asked to be the co-chair of the multi-organizational industry input to CMS, of course in those days it was called HCFA, to develop those regulations, and we sat around in a suburb of DC to hammer out the regulations with Sam Kidder, who was at that time the head pharmacist at CMS. Since 1999, there was a gradual increase back to the former usage of antipsychotics in long-term care, sadly. We went back right to where we were. As soon as we stopped looking, as soon as we took this off the regulatory agenda, things went right back to the way they were. Now, in the United States, somewhere between 15 and 27% of long-term care residents are on an antipsychotic or an atypical antipsychotic. At a later date, I'm not sure exactly of the date that occurred, there was a collapsing of the antipsychotic guidelines, which formerly were separate, into the guidelines, the F329 tag on unnecessary drugs. There's no real reason for there to be different F tags. If they're unnecessary drugs, they're unnecessary drugs. But along with that came a regulatory expectation to do gradual dose reduction and trials of discontinuance of antidepressants. We're really here to talk about antipsychotics today, but if I could just for one moment say that I have been a big opponent of that, and I don't think that we have any evidence basis from randomized controlled trials as to when we should expect to do gradual dose reduction of antidepressants. Obviously, if an elder is on an antidepressant and has an adverse reaction, they should be coming off and maybe substituted something else. But our prototypical nursing home patient has 3 1/3 years to live. And I think that taking them off of an antidepressant that has been successful in improving their condition risks relapse, and there is really no evidence basis for it. Everything else that we do should have an evidence basis. This one seems to me to be an expectation of the bean counters that want to reduce drug costs as opposed to something founded in science. Again, subsequent to the over 87 regulations, the FDA created a boxed warning for atypical antipsychotics that relates to a preponderance of cardiovascular events and deaths in those patients with dementia who are receiving an antipsychotic or atypical antipsychotic. This was done by meta-analysis, and as I'm sure you're aware, you cannot determine cause and effect from meta-analysis. I think it's important to look at this signal, but we've gone a little overboard in terms of the science of it when we shift gears, bait and switch, and start saying that there is clearly a cause that if you're taking an atypical antipsychotic, you are more likely to die if you have dementia. That has not been proven. Nevertheless, I am on board with a reduction in an inappropriate use of antipsychotics, believe me. The FDA boxed warning was very onerous and would appear to create a lot of not only regulatory liability but also legal liability in the event that you're a doctor, you give an antipsychotic to somebody who is elderly and has many other risks for mortality, and then they do die. But in spite of that boxed warning, there has been no apparent reduction in use as a result of the boxed warning. So apparently this didn't frighten any prescribers. The Advancing Excellence Program and the Partnership in Dementia Care have been fairly recent activities of the Center for Medicaid and Medicaid Services. And these have been coupled with surveyor training to heighten the scrutiny of the use of antipsychotics in dementia patients all across the country. The effect of that on antipsychotic reductions is as yet unknown, the full effect. There has been a 18, 20-ish% reduction in most venues of care around the country. But again, this may be the Hawthorne effect, the fact that somebody's looking, and it may not be a permanent change in practice if other things don't fall into place. According to the Center for Clinical Standards and Quality Survey and Certification Group, the indications for antipsychotics look a lot like what is written in the DSM-4, the Diagnostic and Statistical Manual of the American Psychiatric Association, and I would certainly agree with it. The indications for use of an antipsychotic should generally be for those conditions that are in the right-hand margin here: schizophrenia, schizoaffective disorder, delusional disorder, mood disorders such as bipolar disorder, severe depression that's been refractory to an antidepressant alone, or to other therapies, and or those with psychotic features. Psychosis that occurs from any other cause in the absence of dementia is an appropriate use, according to this group, of an antipsychotic and me. Medical illness with psychotic symptoms, such as neoplastic disease, delirium, which could be due to a drug or it could be multifactorial, very common in the elderly, and not necessarily in the absence of dementia, because a patient with dementia is much more likely to develop delirium than one without it. The Treatment-related psychoses or mania that occur are also appropriate uses for antipsychotics. Some of the straggler things would be Tourette's disorder, Huntington's disease, hiccups that are not caused by other medications, and nausea and vomiting associated with cancer or chemotherapy will sometimes respond to some of the old typical antipsychotics. Now, going to the title of the presentation today here again, that reducing antipsychotic is, or the title of the editorial, is education all that is needed? I am on the editorial board for the Journal of the American Medical Directors Association, and in about October they sent me two papers. One was from Finland and was an educational intervention to reduce inappropriate drugs, including antipsychotics, but also including other drugs that are found on the Beers list. And that educational curriculum was given to the nursing staff, putatively with the idea that they would then speak to their doctors as they made rounds and see if there could be a reduction in inappropriate drugs as taught in the curriculum, or that they would be better husbanders of prescriptions at the time of phone calls when the doc starts things on the telephone without the advantage of having a bedside examination. It was important to note that these interventions occurred in nurses who were employed in an assisted living facility, but in Finland, the assisted living facilities look a lot like nursing homes do in the United States. It's also important to know that the nursing staff were all employed by the people giving the education. So it may have been the education that caused them to behave differently downstream, or it may have been the fact that their boss told them what to do. That's again the Hawthorne effect. Another of the papers that was sent to me at that time was a study in Spain by Garcia Golarte et al. That was 10 hours of educational curriculum delivered to physicians and I think some non-physician prescribers that caused their performance to be improved regarding what are considered to be inappropriate medications, including antipsychotics, but not only antipsychotics. It was very interesting that the downstream consequences of this in terms of unnecessary hospitalizations and cost of care started to be visible within the period of the 6 months of this study, which I find amazing, that there's enough inappropriate medication out there causing harm to elders that it shows up within 6 months if you start to practice better medicine. Again, however, this study was done in Spain in a closed staff model. All of these docs and prescribers were employed by the people who were giving that education. So was it the education, or was it the fact that the boss said, do this, or else? Did anybody get fired? Did anybody get a demotion? Did anybody fail to get a raise because they didn't follow the expectations of their bosses? I've actually sent that question to the authors, and I had not yet received a reply, but I did receive a reply from them that they were employed physicians and they were used to receiving advice and typically would accept that advice and follow through with it, that they were compliant individuals as employed physicians. When we think of it that way, I think that the study saying that education is good to fix inappropriate drug prescription is an interesting study, but it's not generalizable to other countries, particularly in the USA, where we have almost always an open staff model. Nursing homes are an open door to any physician or non-physician prescriber who will admit, make rounds, and do the work. And it's been said that leading physicians is a little bit like herding cats when you're in an open staff model. This whole situation also, there's a barrier to the reduction of inappropriate antipsychotics and chemical restraint that's created by, I believe, mixed messages that are coming from CMS and DADS in Texas. There's an expectation for clearly for us to avoid inappropriate antipsychotics and to avoid chemical restraint. But there's a perception by administrators, DONs, and staff nurses out there that there is severe regulatory risk in the event that a nursing home patient is involved in a resident-to-resident event, whether that be violent or sexual or an elopement, or that wouldn't be a resident-to-resident event, but something else like an elopement. You can have a pile of bricks on top of you in a hurry as a nursing home administrator or DON if these events occur. And so the idea of using treatments that are non-pharmacologic and that we know are not 100% efficacious. Every text you pick up, every paper you pick up about non-pharmacologic therapy tells us that the expectation is to lop the top off of the behaviors, to make them tolerable, to decrease the frequency substantially, but it doesn't go to zero. And yet you're at great regulatory risk in the event that any of these things happens even once. It is wholly unlike the treatments we do with physical medicine, where if we're giving an antihypertensive and we get the blood pressures pretty good and the patient has a heart attack or a stroke anyway, which is going to happen part of the time, we don't get blamed for that. But this, the tail wags the dog. We also see some mixed messages in the quality measures which imply poor care if there are high scores in certain areas. Now, I understand quality assurance data to mean that if you have high scores in a certain area, that does not automatically mean that poor care is occurring in that area. There may be an explanation for that score that is an aberration. If you're the nursing home right next to a urology specialty hospital, it's not going to be surprising if you have a lot of catheters or you have a lot of people that have incontinence. If you're downstream from some other kind of a medical facility in acute care where there's going to be a lot of pressure ulcers and your nursing home has a high number of pressure ulcers, that doesn't necessarily mean bad care. Nevertheless, when we look at quality measures, if there are high scores in a certain area, it may indicate and probably indicates poor care processes. And among the quality measures, QM 2.2 is the prevalence of behavior symptoms affecting others. Now, this is one of those, I think, kind of backwards QMs that some of the best places have the worst data. Because if you're picking up on behavioral symptoms that affect other people and care planning them, you get a hickey in your CASPER report. If you're oblivious to this, ignore it and do not care plan it and do not put it on the chart, don't write any nursing notes about it. If a tree falls in the north woods and there's nobody to hear it, does it make a sound? There is a QM 2.3, prevalence of symptoms of depression in the absence of antidepressant therapy. If you look at what triggers that, many of the things that are on there, like staying in your room a lot, losing weight, I can't think of another one, but they're very non-specific, and they many times have some other cause. If you're losing weight, maybe you got cancer, or maybe you got dental pain, and yet it ends up falling into your depression quality assurance data. CMS would like us to believe that by having composite data that every nursing home is going to have some noise in there, and we're comparing nursing homes, so it should all come out in the wash. But nursing homes aren't the same. They're very different, and when we're dealing with an N of, let's say, 100 people in a nursing home, it's very easy for chance to modify these things and make it look like there's a problem when there isn't. Additionally, both of these things are speaking to encourage the nursing home to do something about these problems. And if the do something is non-pharmacologic treatment or pharmacologic treatment, then downstream here in this talk I'm going to show you why pharmacologic treatment often wins out, because that's what we've got. And the other thing, non-pharmacologic treatment, is out of our reach, economically, staffing-wise, and so forth. Also, the QM 2.3, prevalence of symptoms of depression without antidepressant therapy, implies that you're supposed to treat it with a drug. Now, I treat a lot of people that have depression without a drug. I may exercise them. I may give them brief directive psychotherapy, reframing, a variety of tactics. May give them sunlight and get some pretty good effects. And depression doesn't always mean major depression, which is a biochemical problem of the brain, a neurochemical problem of the brain. Signs and symptoms of depression could be occurring because the patient has a normal depressed mood, because they've lost health and vigor, because they had to go to a nursing home, because they can't live at home, can't be where the dog is, so forth and so on. Being depressed does not imply a disease that needs to be treated with a medication, because it's not a biochemical, neurochemical, anatomic problem. It's life. QM 10.1 through 10.3 imply better care if there is less use of psychotropics. So we're getting this, the schizophrenia is not always in the patient. Some of it's in the regs. And finally, we have a system of mandatory inquiries by the consultant pharmacist. These are required by CMS, that the consultant pharmacist inquire of the physician to make the gradual dose reductions at various intervals. I've already commented about the inappropriateness of that, in my opinion, on antidepressants. And then the antipsychotics, my biggest worry, set aside the issues of this presentation, is that our consultant pharmacists are many times coming in looking for all the patients that are on an antipsychotic, and carte blanche sending a mimeographed note to the doctor, because it's been 6 months, why don't you withdraw that drug? Why don't you do a gradual dose reduction? They haven't looked at the diagnosis when they make that. If a doctor is not very engaged, if he's off-site, doesn't have the chart, isn't very concerned, wants to take the easy route, he'll agree. He'll say yes, he, she. Well, what if that patient has schizophrenia? Somebody's going to get killed out there if you take the patient with schizophrenia off of their antipsychotic. And sometimes when you take people off of antipsychotics that need them, and they go ballistic, and you give them back the antipsychotic, it doesn't work anymore. You've lost your opportunity to keep that patient well. It is part of my editorializing that I believe there is a systematic underfunding of the long-term care industry. I think the problem is mostly in the area of staffing, and the Institute of Medicine has at least twice done a white paper that agrees with me. It says that the biggest problem with quality in long-term care is inadequate numbers and inadequate training of direct care staff. I would say that particularly applies to the nursing aid staff, the frontline backbone of our industry. And I personally believe that 72 hours ain't enough to prepare a CNA to be on the floor and take care of the most frail people in the United States, who have, because of their age, have more unusual presentations, subtle presentations of their changes of condition, and who many times are unable to communicate with their caregivers. And so it's like Pardon me, I'm not saying that nursing home patients are animals, but it's like veterinary medicine, or it's like infant pediatrics. You can't expect the patient to tell you with words what's the matter. It's a lot more difficult than that. And they call them nursing homes because the nurses are there. They don't call them doctor homes because the doctors generally aren't there. We're getting our information on the telephone. Nurses are the eyes and ears of the physician, but the nurses' eyes and ears are the CNAs. And if they don't know what XYZ physical finding means, or XYZ change in Blanche this morning, she's different than she usually is. She's got such and such. If they don't know the significance of that, they may not, frequently don't report it to the nurse. If they do report it, they may not report it accurately. It gets blown off, and changes of condition get way down the line before they're recognized for what they are. And then we get criticized for it. Nursing homes are paid based on either resource utilization groups or tile levels in various states. There's some difference. I'm not privy to the difference between those two, but in either case, patients with similar needs to receive resources are grouped, and the nursing home is paid on that basis. In Texas, special rehabilitation scores a 14 on the RUGs, physical function a 10, being clinically complex a 6, impaired cognition 4, behavior problems 4, extensive services 3, and special care 3. Now, I don't know about you, but I will trade you 4 special rehabs for 1 behavior problem, because the resource sponging, the resource utilization in these cases is incredibly high, along with the risks and the emotional strain of caring for these folks. Some of the unrecognized or under-recognized aspects of BPSD, behavior and psychological symptoms of dementia, are providing objective symptom monitoring, evaluation, and reevaluation. In order to get the diagnosis in the first place, you need to objectively monitor the symptom. How many times a day, a week, an hour does a behavior occur? And when during the day does it occur? Under what circumstances? All those things need to be sleuthed out. We're going to talk about that in another talk. The time to collaborate with physician or the non-physician prescriber, with all of the other members of the interdisciplinary team and with family, is a cost. Inadequate numbers and training of direct care staff for needed supervision and interventions. This is probably the biggie. You know, the biggest cost center for most nursing homes, the biggest line item in the budget is labor. And so if we have somebody that is hitting other people without any trigger, without any escalation that you can see beforehand, they hit without warning, without any notice, you basically have to put a one-on-one on that person. Sometimes you can get away with what I call line of sight, so you might have one staff person in proximity of 3 or 4 patients, but you got to have them close enough where they could step in when the person goes like this towards another individual and get in between. Sometimes basic milieu supervision is sufficient, meaning there's enough staff wandering around randomly doing their work so that they can take care of a behavior if and when it surfaces. That all has to do with the severity and the frequency of the behavior, and staffing needs to float with that. Needs to be very effervescent in terms of the numbers and assignments that we have. And that's not the way nursing home medicine gets practiced these days. Many times activities, individualized activities, becomes one of the major interventions that we do. We want something that competes with the problem behavior, that if they're doing that, they can't be doing this. You know, idle hands are the tools of the devil. And Yet this would require not a CNA or a nurse to be one-on-one or two-on-one or three-on-one with the individual, but with an activities therapist that is. And then finally, there's an increased cost that I think is unrecognized in terms of the downstream cost of citations by the regulatory system, or more importantly, in much bigger numbers, legal risks in the case of a lawsuit in the event of a serious event with consequences. If we look at what is good about drug treatment, what tends to support it in our current system, pharmacologic treatment of BPSD is costly to Medicaid and Medicare, but nobody denies the payments. If they go in, these get paid. The nursing home isn't going to lose any money. Minimal interdisciplinary teaming is needed, so you're not burning staff time and dollars with a bunch of people sitting around a table trying to work out the problem. Just give them a drug. Minimal staffing time as far as delivering the care. You do the med pass, you're done. There's not the one-on-one, there's not the increased activities, there's not the interventions that require staff time. There's no need for consistent staffing, which is one of the buzzwords of personalized care now, person-centered care. It doesn't matter who gave that pill. And there's minimal collaboration with the family after we get permission to give the drug, after we give a basic informed consent, which in my opinion is usually pretty sparse and not specific to the individual drug that's being given. These drugs all have different characteristics, different side effects, but the handout you got from the state about these makes it look like they're all the same in terms of the risks. To go on with pharmacologic therapy, the tile level or RUGS level validates, money talks. And so if the price is low, then it must be that the expectations for the care are low. Telephones and fax machines. They're way high on my list of things that if only we could somehow find a way to get rid of them, because these create the way that a physician can, from off-site, deliver care without an examination, without follow-up, and yet it's a system that's there, it's easy to use, and it tends to support the use of drugs rather than non-pharmacologic therapy. Regardless of what's said about the efficacy of antipsychotics, there is efficacy there in terms of sedation. Now, the true therapeutic goal of most antipsychotics is not sedation. Sedation for a psychiatrist or a geriatrician who practices behavioral geriatrics like myself, sedation is only a therapeutic benefit in an acute agitated situation as a stopgap measure. Yes, sometimes I use chemical restraint in order to get the group together and figure out what's going on, but it's not an ongoing treatment. Sometimes I use chemical restraint when there is an event that will repeatedly cause the elder to go ballistic. There's no reason, if you're going to do dental work, to have the dentist get pounded around the head and neck during the dental work. That patient needs to have a sedative so that they can get through the thing, not only without hurting anybody else, but also so that they need not be hurt physically or emotionally. But chemical restraint often occurs, and if it doesn't, at least that's what's in the mind as a therapeutic goal for the prescriber and many times the nursing staff, a belief that there will be efficacy by sedation. When we give a drug, there is a clear black and white appearance that we're trying to protect others. And finally, up until now, there's been minimal regulatory risk and liability for the nursing home. Now, with the increased emphasis on this, we're increasing that regulatory risk. I do a lot of med mal, and I haven't seen an increase in liability from a standpoint of lawsuits. But let's look at that last bullet another way, and that is, if a facility is doing an egregiously bad job and loading everybody up with inappropriate antipsychotics to chemically restrain them, who gets in trouble? The nursing home. The prescriber doesn't get in trouble. I have yet to see any consequence for the prescriber, except fewer phone calls. Non-pharmacologic treatment. What's a barrier to it? Well, it's costly. I've gone through that, particularly in terms of labor costs. It requires a maximal teaming effort, both in terms of labor and also the education and skills of those team members. And by the way, it requires that we all, if we don't like each other, at least we need to be cordial to each other and collegial and find ways to work together. Find ways that when we disagree, we use those disagreements as a strength rather than a weakness. Maximal staffing time is required with non-pharmacologic treatment, and there is a need for consistent staffing. And that's a hassle for the scheduling lady. Trying to get kids' schedules and school schedules and doctor's appointments and everything to work out so that usually we can put a certain CNA and a certain nurse with a certain patient consistently. And it requires maximal collaboration with family, and God bless them, some of our families are wonderful and are crying for this, and many others aren't. So even in the best of worlds, we might be looking for hen's teeth as far as collaboration with families. The tile levels and rugs levels, again, are inadequate for the nursing home to profit from care if that care is state-of-the-art. I hasten to say, if the care is state-of-the-art. Nursing homes are a business. They have to make money. Money creates quality for the residents. It's not evil. And yet to do proper care, state-of-the-art care in this arena would require the nursing home to lose money. Maximal involvement of the provider in the IDT, that's getting the doctor to come, handing him a cup of coffee, him or her a cup of coffee, sitting down at the IDT meeting and conversing with the other members of the IDT, brainstorming what's the cause of this behavior problem. We need to also recognize that it's a huge barrier when there is regulatory and legal risk to use non-pharmacologic therapy, because virtually all non-pharmacologic therapy can promise us only partial or incomplete improvement, and cures are rare. What cures BPSD is progression of the dementia. When they get bad enough with the dementia and they're laying there without any speech, without the ability to smile, without the ability to ambulate, behaviors aren't going to happen. But that's not my goal. I would like to wake that person up to the point where they could take a poke at me again. They'd be better. And non-pharmacologic therapy creates maximal regulatory and legal risk. No wonder we have a hard time getting this plane to fly. There was a VA study done in 2011 which looked for an evidence basis of efficacy of non-pharmacologic interventions. They did meta-analysis cruise through all of the available literature, and they found that only a few of the tactics of a non-pharmacologic nature for behavior problems were efficacious. They don't work very good. And the ones that did work, worked a little bit. Now, I think the problem with the study is similar to the reason that we have data on antidepressants, that no one antidepressant is better than another antidepressant. And so if you're just picking something off the shelf and throwing it at all your customers, it's not going to work. What we need to do is have a stock of non-pharmacologic therapies, and from that stock pick the one that fits that patient. But when I say that, how did we get there? We had to sleuth the behavior problem to figure out what do we think the cause or causes, to make the problem even more complex. What are the causes, so that we can maybe tailor-make an individual, person-centered intervention that may have a hope of altering the behavior. Probably non-pharmacologic interventions must be highly individualized to be modestly effective. Again, no cures are rare. And I've cited that, so if anybody wants to read that paper, I heartily recommend it. Just remembering here that one of the axioms of the old OBRA, which I disagreed with at the time, was that non-pharmacologic treatments must be tried and fail before you can do a pharmacologic treatment. That's kind of not how it should be. Certain diseases, certain behaviors, once you sleuth them, turn up to be a neurochemical disease of the brain, in which case pharmacologic treatment is the sine qua non of treatment. And to not give it would be malpractice. Almost all of those patients also benefit from a non-pharmacologic therapy, so that drug and non-drug therapies should be wedded together for the best outcome. A few patients, probably the lion's share in dementia, don't need a drug at all, and they need a non-pharmacologic treatment. But you don't do the non-pharm one, and then it fails, and that means that the drug is good, because the drug wasn't ever good for that disease. No behavior is the sine qua non of any disease, so we need to go very carefully over other things than the fact that the patient hits other people in order to figure out what intervention should I use, a drug or a non-drug intervention. The patient is hitting other people. Wait a minute, who are they hitting? They're hitting people of the opposite sex. They're hitting people that they perceive are weaker than they are. They're hitting people that come into their territory. They're seeking out and hitting one particular guy. They're hitting the staff when they're delivering personal care. Every one of those circumstances of a person hitting other people gives us a clue as to what's the cause of that. The hitting doesn't help us at all, and could be caused by dementia with depression, dementia with pain, dementia with urinary urgency. Just go through the list of 1,000 things, and you've got to go into that detail. But that detail requires a lot of staff time and energy. I was on the Advancing Excellence Committee, both nationally and at the state level in the past year, and repeatedly on the teleconferences and in the emails, I received a list of best states to worst states for what was thought to be inappropriate use of antipsychotics. Texas was the worst state. We've actually moved up to second worst now. Somebody else got the worst slot. Nevertheless, our data looks pretty bad. Repeatedly during those meetings, I asked CMS to give us a list of states from best state, or shall I say most generous state, to least generous state, for the tile level or RUGS level to take care of behavior problems in the nursing home. And they wouldn't do it. So when the Journal of the American Medical Directors Association asked me to write an editorial in response to the two it's easy. All we got to do is teach the doctors what drugs to use and what not to use, and everything will be hunky-dory. That was the meaning of these two papers that came in, one from Finland and one from Spain. And I said, horsebucky. Sorry, horsebucky. That's it. That can't be it. That just isn't right. We did that before. We did that in '87. We did it again in '92. We got some little blips because of the Hawthorne effect, and then it went right back to the bad situation it was before. I was unable to get the granular detail of finding the RUGS levels or tile levels by state. But I did find a Kaiser Family Foundation website which gave me the most generous state to the worst generous state for Medicaid reimbursement to elderly recipient. Now that doesn't even give me the granularity of in the nursing home or outside the nursing home, but if we believe that perhaps the RUGS level or tile level for granularity, the behavior problem in the nursing home, tends to track with the overall generosity of Medicaid for elderly people, and I think it probably does, I found a significant correlation between Medicaid reimbursement per elderly recipient and the state's ranking for antipsychotic use. The top 5 states, Hawaii, Alaska, Michigan, and Columbia, rank 18, 3, 17, and 5 in generosity of Medicaid reimbursement per elderly person, whereas the worst 5 states in the United States, Tennessee, Illinois, Mississippi, Louisiana, and Texas, rank anywhere from 36 to 47. That looks like a correlation to me. It's not a perfect one, but it's pretty clear there's something going on here. That said, the regs are the regs. They are the law of the land in terms of reduced from the law to being a regulation. And so this is a job we have to make an attempt to do, and I would encourage us all to make a bona fide attempt to do it, and do it as well as we possibly can so that no part of this unsolved problem is because we have not done our job. And so what can we do? Ways to decrease inappropriate antipsychotic use in your facility. Identify and encourage prescribers to discontinue all PRN antipsychotics. There's no science to this. These drugs, to be effective for anything other than sedation, which is chemical restraint, and we should not do it most of the time. In order to get any of the other therapeutic targets hit with an antipsychotic, you need to have a tissue level. And that means you need to be giving the antipsychotics on a scheduled basis for a number of days. By the way, it's 5 times the elimination half-life. It's how long it takes that drug to reach an equilibrium in that person's system. So if a drug has a 3-day half-life, you need to give it for 15 days before you look and say, is that dose right? Is it too much or too little? And you can take any drug, go to the elimination half-life, multiply times 5, and that's going to give you the time for reassessment. Big point, though, that I was trying to make is antipsychotics need to be given on a scheduled basis to achieve anything other than sedation, and sedation is not an appropriate therapeutic target except in very narrow emergency and reoccurring situations. The next thing that you can do in your facility is get rid of all the Seroquel orders for sleep. There are lots of better drugs for sleep, and there are lots of non-pharmacologic things that we should do for sleep, not the least of which is don't just take the elders' insomnia complaint to be true. A significant number of elders will say that they're having trouble with insomnia, and if you ask the CNAs to do a flashlightless check on them, they're sleeping soundly all night long, or maybe getting up twice to go to the biffy. But they complain about sleep when they actually have no problem with it. Also, the older you get, the less you need to sleep. And so an elder may complain that they're not sleeping 8 or 10 hours a night, but they took 4 naps during the day. And maybe they only really need about 4 hours of sleep. They might need more rest. So the real question is, when you get up in the morning, are you refreshed, or are you nodding off all morning, all afternoon, before you can make the diagnosis of insomnia? The Seroquel is highly inappropriate to be used as a sleeper and needs to come off those charts. Other ways to decrease inappropriate antipsychotic use in the facility: identify and scrutinize all antipsychotics for appropriateness when the patient comes to you from the ER, the hospital, another SNF, or an ALF. You don't know who's over there and how they determined whether that patient needs to take Risperdal. So you've got to try and get their records of how and why the drug was initiated. Certainly the patient may not look like they need Risperdal. And if you don't do the sleuthing, you take them off the Risperdal, and then pretty quickly you're scraping them off the ceiling because they did need it. But you got to go back to that hospital record or ER record to find out that the patient believed the Martians were landing, or that drug dealers are trying to kill them with Uzis, in order to understand why that patient is on that medication. The next one is to identify and scrutinize all antipsychotic orders that are generated in-house. And of course, to get this cleaned up, you need to do this once for all orders for antipsychotics, the old ones. Once you do that one time, go to that extra effort, then you can just pick up any new orders. And that's a fairly easy job for either a DON, a medical director, or a consultant pharmacist to do. Just make sure that every new antipsychotic gets looked at by one of those three individuals to see if there's appropriate documentation. Look for documentation of true psychosis to justify the use, not words like agitation or behavior. I see all kinds of charts that do make the good step of saying on the monthly printout that the patient is receiving Seroquel, and then it'll have a diagnosis there and it says dementia with behavior or dementia with agitation. That will not fly. Dementia with psychotic features, government doesn't like that. They're going to scrutinize it carefully, but if you've got documentation of true psychosis, you'll be okay. When I say documentation of true psychosis, that takes a little experience, but let me give you the general drift. Lots of people, my dear grandmother on my paternal side, believed that when she was living in her house, believed as she got demented, that the neighbor was coming in and stealing things. Paranoid ideation, right? Psychosis. Oh, wait a minute. She was a highly independent individual, and when she started to get dementia and lose things, she couldn't live with that explanation. So she had to come up with an egocentric explanation, the neighbor is stealing from me, to explain it. There is not a problem with brain chemistry other than dementia. It's not a dopamine excess in the mesotemporal lobe. It's her dementia that's creating that. That's called a simple delusion, and we need to be very careful about those. Just another example to take home and remember is that if the elder is sitting in the nursing home day room and they're wondering, who are all these strangers in my living room? That's dementia. If that same person is sitting in the day room and wonders, who are all these Martians in my nursing home? That's psychosis, okay? And that's how you decide whether an antipsychotic is justifiable or not. And that's the granularity of the note that needs to be written. Agitation, behaviors, don't cut it. More ways to decrease the inappropriate use: identify all residents who truly have schizophrenia, Tourette's, Huntington's, delirium, and highlight those diagnoses as the real reason for the antipsychotic. Be very clear in the record that these are the reasons. Incidentally, that other list that was more extensive than this, that didn't come from the CMS guidance to surveyors. The guidance to surveyors trimmed that way down to only these diagnoses: schizophrenia, Tourette's, Huntington's, and delirium. Now, they're wrong. They're wrong as hell. But that's the reg. So any of the other places where I would say, and the other groups would say, antipsychotics are appropriate, the sine qua non of treatment, malpractice not to give them, you need to really raise the bar on documentation in order to make it fly. Surveyors are not evil, even when they're administrating a bad regulation. And if the documentation is there, and if there's clear justification that the patient was worse off before they got the drug, better off with the drug, you'll be fine. Do gradual dose reduction to discontinue the drug at 6-month intervals on residents with antipsychotics for dementia with psychosis. So the use of the antipsychotic was appropriate. They had psychotic features. They had dementia with Lewy bodies, and they're seeing children running around in the nursing home that aren't really there, and they think some of them are trapped in the wall. That's a real delusion I had with the one guy. He was miserable. He wanted to save those little children. It was absolutely to his benefit to receive an antipsychotic. The delusion went away. He was calm. He was happy. That's what my notes said. At 6 months, it's time to try to gradually withdraw that drug and see whether the symptom comes back. If it does, you start it up again, go another 6 months. If it doesn't, then the drug can be discontinued, because most of these people pass through that psychosis and out the other side and don't need the drug for very long. That's typical of this disease process. Now, if you do a gradual dose reduction twice, and both times the patient relapses, it's okay to stop doing gradual dose reductions at 6-month intervals, as long as you write a good note that says you're going to do that. And then you say, I'm only going to try gradual dose reduction again someday if the patient gets an adverse drug reaction, or if their dementia progresses significantly so that I believe that the psychosis is no longer a clinically important event. Care plans to do you should always, in order to reduce the inappropriate use, look for adverse events, because even if the drug was indicated for the diagnosis, if the patient has a burdensome adverse reaction, that drug is inappropriate. And so we should have care plans uniformly on all patients on antipsychotics and atypical antipsychotics to do the abnormal involuntary movement scale, AIMS test, on a regular basis, 3 months, 6 months, maybe a little bit more often when you first start up a drug, and then to monitor for adverse drug reactions with a review of the benefit and burden ratio if there is an adverse. You don't always have to stop a drug if there's an adverse drug reaction. You're given a little Risperdal, they get a little bit of extrapyramidal tremor, but they don't spill their coffee and they can read their newspaper, and their psychosis is gone. They're way better off with a little tremor than they are without the antipsychotic and with the psychosis. So you got to do a benefit to burden ratio, but the documentation needs to be there in your notes. Harkening way back, talking about prescribers, and I'm a medical director of 3 facilities, one of which the docs on my staff are all super people. I can talk to them, I can reason with them, and they can argue back sometimes, but they're respectful and they're wise. And I can usually get a lot of compliance out of them. At other facilities, not so much. And a medical director doesn't have much to work with. You can cajole, you can reason, you can schmooze, but there's not much else you can do. Very few nursing facilities in the United States even credential their physicians to be sure that they are physicians or nurse practitioners or PAs. And so with that lack of governance, it's not surprising that we also don't have written rules and regulations or bylaws like they do at the hospital. If somebody doesn't make their daily progress notes, see the patient in the hospital, make daily progress note, they get in trouble. And that doctor doesn't get angry with the medical staff because it's in writing, it's in black and white. You knew when you signed up that this was an obligation. Not so in the nursing home. The 30, 60-day regulatory visits many times don't occur. Changes of condition occur and the doc doesn't make a bedside visit. Antipsychotics are given without proper documentation. It may be that the antipsychotic is perfectly justified, but the documentation isn't there to support it. And in the absence of bylaws, rules, and regulations, there's not much we can do. Medical director can do some things, as I said, but frankly, there's a lot of variation in the engagement of medical directors. Some medical directors are very involved and ready to go and have a conference with errant physicians. Others wouldn't touch that with a 10-foot pole. Now, coming soon, I am scared to death of what's going to happen to long-term care when the bean counters get a hold of us through managed care or accountable care organizations. However, one thing that I'm quite clear about is that this lack of governance in the nursing home ain't going to be that way once there's a good solid penetration of managed care and ACOs into long-term care. They're not going to put up with this. If standards of practice are not being met, if clinical practice guidelines are routinely ignored without any note to say why you're deviating from standard of practice, a managed care organization is just going to disenroll your butt right out of the medical staff. There'll be a lot of docs that say, fine, I don't have to be there then, but the ones that remain will be much more tuned in to direction and management. Getting prescribers to comply, there are a couple of other techniques. One, very quickly, that we can all do is to identify our champions and our offenders. Know what your doctors are doing, and that means don't just use the Casper report about the frequency of antipsychotics. Go to the grid that shows you which residents are on antipsychotics and write down what doctors attend them. Now you got to take that data with the grain of salt that how many patients does that doctor have? One doctor may have the preponderance of antipsychotics in the facility, but they've also got the preponderance of patients in the facility. So it's going to be the percentage that's meaningful, not the absolute number. Once you have identified the champions, if you have a resident coming in from outside that doesn't have a doctor, steer them. Steer them to the guy or gal who works with you. Don't steer them on a equitable basis to all doctors out there in the field in the belief that that's going to make you a hero with that doctor and he's going to send more patients to your nursing home. That ain't happening. Medical director and consultant pharmacists need to collaborate extensively on these matters. Consultant pharmacists tend to make their visits at a different time than your medical director does, so it takes an effort to make this happen. But you know, in this day and age of emails and telephones and faxes that I was arguing are a problem before, we don't have to be face-to-face to collaborate on some of these things. You should show attempts to modify prescribers' behavior in your QA minutes, whether you're effective or not. This will help you as surveyors. The surveyors can look in your QA minutes, and you can see you tried like hell to get Dr. Schwartz to get so-and-so off this PRN Geodon shot that you feel is inappropriate, and the doc won't do it. You can't change a doctor's order. But what you can do is show in your quality assurance minutes that you made an effort to do that and defend yourself when the surveyors are there. Remember, it's not the doctor that's going to get the citation, it's the nursing home. They still may give it to you, but they may cite it and not find it. The other thing about sticking it in the QA minutes and not somewhere else is that QA minutes are not discoverable. So you're not creating a legal problem for your errant physician. There's no reason to do that. That's an atomic bomb that you don't want to explode. So this stuff belongs in the QA minutes where it's not accessible by the general public, by the patient's family, or by lawyers. Send prescribers the usage data of all prescribers. Here's Dr. A, here's Dr. B, here's Dr. C, here's Dr. D, here's Dr. F. Dr. D looks really crappy. And then you let them know which doctor they are. You're Dr. D. The other doctors on there, A, B, and D, or E, rather, are not identified to the person reading the data. So you're not breaking any confidentiality, but they can see those numbers, and doctors hate to be outliers. And it's a very, very powerful way to bring an errant physician back towards collaboration and consistency with other physicians in terms of the delivery of standard of care. Not only useful with antipsychotics, but everything else. As a last resort, you've got to pay a doc that is just not complying, that's creating all kinds of trouble, that you're at regulatory risk, and that the patient is suffering from bad care. Talk to the family. This seems to be something that nursing homes are very resistant to do, but there comes a time when the harm being done to the patient has to supersede a relationship you have with an errant physician, a physician that's not giving good care. And if not, you're in collaboration with that doctor. You're sharing that injury to the patient. So there's a time when you need to have a chat with the physician, or with the families. Recognize that sometimes families love that physician so much they'll blow you off. Write it in the chart. Write it in the QA minutes. Keep it where it's protected, but document it so the surveyors can see you made an effort. That's your last resort, but then declining admissions to a severe repeated offender doctor is another way to go, and that's a last resort, and it's one I have used on 2 different occasions at 2 different nursing homes, where the doctor's behavior towards her patient was so severely out of line, and families wouldn't change doctors, that it was time to say, we're just not taking any more patients from you. We'll put up with the ones we got, but we're not taking any more. Most doctors don't care. It isn't going to change them, but you're not going to have the headache. Down the line, you're going to wash those patients out, and you won't have that guy on your medical staff to cause you trouble. I'm going to come back to the learning objectives here. We gave this at the beginning of the session, but let's do it again. I hope that at the end of this session, you can now report confidence in defining what inappropriate antipsychotic use is and what documentation is needed in order to justify appropriate use to a surveyor. I hope you can express an awareness of the tactics that you may use to reduce inappropriate antipsychotic use in your facility. I hope you can list several strategies to encourage compliance by your prescribers with the reduction of antipsychotics. And the last one, be able to explain the barriers to compliance to the public and legislators that is created by inadequate resourcing of long-term care and by lack of evidence basis for non-pharmacologic treatment chosen without individualized care planning and delivery. If we review, what did we talk about? We talked about the systematic underfunding of the industry, which doesn't allow us the time and ability and skill levels of employees, nursing and CNAs, activities therapists, social workers, to do the interdisciplinary teaming that will supply resident-centered care for the patient with behavior problems in dementia. And in the absence of that, we need to tell our story to our families and explain to them that if they don't think mom is getting good care and they want us to do a one-on-one so that she doesn't wander out of the facility or so that she doesn't hit somebody else, so that she doesn't have a sexual encounter with another resident, they need to understand that it's not because we don't want to do that, it's because we don't have the resources to do that. And what they need to do is not harangue us to do Mission Impossible, but to talk to their legislator. Given the numbers involved, if every family member who has encountered this situation and wants more care for mom or dad than they're getting would call their state legislator and put a bug in their ear, this would change. Finally, we make up a fairly large cadre of individuals if we line up all the long-term care docs. The regular docs probably aren't going to do this. But if we line up all the long-term care doctors, all the administrators and DONs, all of the nursing home staff nurses, and all of the CNAs, and think of ourselves as a PAC, think of ourselves as a political action group, how many votes is that? Do you think that some of these legislators might pay attention and put something into their legislative agenda that would help us? If we think about it, we still have a paucity of jobs available, and particularly jobs for less educated people. The nursing home industry, if the CNA workforce was to double, would absorb them overnight and make excellent use of them. And there'd be that many more people that would be taxpayers and that would have meaningful employment. We're a service economy in this United States, and this is where we need to go. And long-term care has not been an advocate for itself. And so that's what this last learning objective is that I'm holding your feet to the fire to get out there and be an apostle for the care, the excellent care that we know how to provide but can't do because we don't have the resources. Thank you. Questions? Oh, probably. Actually, I've been on the assisted living task force in Texas at one time a number of years ago, and left it because what's happening is that a variety of clinical problems are occurring there because of misunderstanding of what services and scope of delivery the assisted living is responsible for. I think part of this is created by assisted living industry itself with their marketing approaches, pamphlets, and what they say to people who are potential customers about, oh, we can do everything that a nursing home can do, but you don't have to tell mom you went to a nursing home. I think some of it is just lack of education of the differences in these two venues of care, so that there's been a study done of the attitudes of emergency room doctors. And emergency room doctors as a group have no clue about the difference of scope of responsibility at an ALF than at a nursing home. So inevitably some problems arise. We're dealing with elderly people, so problems are going to arise. And if something has occurred and it gets to the state as a complaint, the state's immediate reaction, because what tools do they have? They think if the only tool you have is a hammer, everything looks like a nail. So let's make some regulations. If we keep responding to this and add some more regulations for MedPass, add some more regulations for elopement risk for Alzheimer's units at ALF, this, that, and the other thing, what we'll do is we'll turn ALFs into nursing homes. And there won't be the choice, the array of venues of care that are so important. I think nationally AL is trying to put aside its earlier platform that it represents the social model of care and the nursing home, the medical model. But I'm going to hang in there. I'm going to be one of the old timers. I think that's appropriate. And I don't think that we end up with assisted living being people that are less sick and skilled more sick, because I could be more sick but not want any of the high-tech stuff that happens at a nursing home or even at a hospital. I think that's how we ration ourselves based on our goals as human beings. And I'm certainly looking forward to being an AL resident, not a nursing home resident, because I don't want any of that stuff. I do a lot of it because people want me to do it, but it isn't what I'm going to want. I'm not going to want a PEG tube. I'm not going to want an IV, etc. And the CMS knows that in order to have a significant effect or a thorough effect on antipsychotic use in nursing homes, which is kind of like the hot spot of this, that they also need to get at misprescription that's happening in the ER and in the hospital, and also in AL. The outpatient practice of medicine should be governed different than institutional practice of medicine, but the standards of care should be the same. I do think that if we were successful in applying regulations along with proper resourcing in long-term care, that the learning that prescribers get in the nursing home will translate into the way they handle their patients in offices, in ALs, and in the hospital. Yes, but with differing skills and ability and penetration of that system. That is a wonderful system, and it really helps the provider to format their thinking before they communicate it upstream to the nurse and then on to the doctor. but the zeal with which that has been embraced at different nursing homes by the executive nursing in order to make it happen at the CNA level, and the usefulness of the training, and then finally the skill level and engagement, the interest and responsibility of the CNA varies. We're dealing with people here, and that's one reason why I would like to see more CNAs on the floor, so they aren't so hard worked, aren't worked to the bone. And I'd like to see the wages be up so that we can attract the best people to this, and so that if somebody comes with less than 100% motivation, once they see how we treat this level of employee, they find value in that position so that they want to do better, so that they aspire to be an excellent CNA as opposed to just getting by. Yeah, it sounds like a good workup has been done to be sure that the patient doesn't have the feeling of needing to void, even though there's not urine in the bladder, which is certainly possible. In my experience, the other explanation for this is attention seeking. And it may be that the individual has, we don't know the cognitive level, but if the cognition is kind of in that middle bad zone, this patient may actually have some other unmet need that they are unable to express, and so they're saying, I need to go to the bathroom. So we'd have to completely look for anticipate all other possible unmet needs. But probably we're dealing with a request for attention. We would need to know a lot more about this elder to speculate about why that is. Need to know who they were before they developed dementia. And what is it they want? Do they want a hug? Do they want verbal stimuli? Are they bored? Are they depressed? And then go after that. And that's what I said earlier. The behavior seldom tells you what's the underlying problem. The behavior is pretty much, what the problem behavior is pretty much useless to figure out what's causing it. And we need to go to a whole bunch of other things. If you remember, well, I guess it's in the other lecture, the circle of reasons for behavior problems in nursing homes, the categories. You're going to have to search all of those to get the answer. The average is there is no average. President Reagan said it one time in one of his talks about Medicare and the elderly, and I think it was actually maybe it was a press conference where a reporter was commenting upon his viralness and his high activity level. He's still out there riding horses and stuff, and he said, quote, "All elders are not the same. When we are little babies, we're all about this big. We've got our lab. If you look at the lab normals for an infant, there's a very narrow margin of normalcy from the low end of the hemoglobin to the high end of the hemoglobin, the low end of the sodium to the high end of the sodium. The older we get, the more we diverge from each other. So that in old age, we are incredibly different from each other. And if you've seen one elder, you've seen one elder.